Welcome to VJOncology podcasts. In this week's episode, we'll explore the evolving landscape of immunotherapy in gastrointestinal malignancies, spanning from perioperative to adjuvant settings across multiple tumour types. This podcast is available on the GI channel on VJOncology, an independent medical educational platform which is supported by Takeda and Gilead Sciences. Supporters have no influence over the production of content. The levels of sponsorship listed are reflective of the amount funding given. Optimizing combinations in MSI-high colorectal cancer is of utmost importance. Dr. Filippo Pietrano discusses results from the Phase II KEYSTEP-008 platform trial, which evaluated pembrolizumab-based combinations in MSI-high, mismatch repair deficient metastatic colorectal cancer.
KEYSTEP-008 study is a platform Phase II randomized clinical trial, and this study was dedicated to patients with MSI-high or deficient mismatch repair metastatic colorectal cancer. Basically, there were two cohorts in the study. In cohort A, patients were pretreated with the three main chemotherapy agents, fluoropyrimidines, irinotecan, and oxaliplatin, and anti-GFR monoclonal antibodies if clinically indicated. And in this cohort, patients were randomized to either standard of care pembrolizumab or a combination of pembrolizumab with the anti-CTLA-4 monoclonal antibody quavonlimab, and this is a co-formulation. So basically, in this heavily pretreated patient population, the overall response rate was higher with the combination, 45% overall response rate versus 30% with pembrolizumab alone, and there was a numerical increase in terms of efficacy endpoint, including progression-free and overall survival. However, the patient number, 60 patients per arm, was not sufficient to show any statistically significant difference. Also, it is important to note that nowadays the use of immune checkpoint inhibitors is recommended by all major guidelines in the first-line setting, and so cohort B of the study investigated different pembrolizumab-based combinations in the first-line setting in patients not previously treated for metastatic disease. And so the 5 arms of the second cohort of the study investigated pembrolizumab alone or in combination with other agents, including quavonlimab, as in cohort A, but also other agents such as the anti-LAG3, favezelimab, and the TIGIT, vibostolimab, and also the ILT4 inhibitor acting on macrophages receptor, MK-7840. So basically, in these cohorts, there were no significant differences in terms of response rate or progression-free survival, overall survival. So basically, in this patient population, actually combining pembrolizumab with an additional immune checkpoint inhibitor didn't provide any additional benefit compared to monotherapy with pembrolizumab alone. Of course, we know that today the standard of care for most patients is the combination of ipilimumab and nivolumab in the first-line setting. So, of course, this is the current standard of care, and additional agents are needed to further improve the outcomes, but the outcomes are really, really good with the combination of ipi-nivo. So it will be difficult to really achieve better results than the current standard.
Next up, Dr. Olatunji Alesi discusses emerging biomarkers for immunotherapy beyond microsatellite instability in colorectal cancer, including results from the TAPUR trial, which evaluated nivolumab plus ipilimumab in patients with colorectal cancer and BRCA1/2 alterations.
So there have been a few published data, especially in the preclinical or animal models, showing that when there are DNA repair abnormalities, which is one of the hallmarks of BRCA alterations, you have immunogenicity, you have a high neoantigen load. Because of the genomic instability, occasioned by the abnormalities in either BRCA1 or BRCA2 genes. And so that was really the rationale for trying to target that immunogenic abnormality by using the checkpoint inhibitors nivolumab and ipilimumab. So the TAPUR study is a Phase II basket study that is being sponsored by the American Society of Clinical Oncology, or ASCO, and it utilizes commercially available agents in patients with advanced malignancies. By trying to target specific molecular abnormalities, we reported out at the 2026 GI ASCO the cohort of patients with advanced colorectal cancer and BRCA1 and 2 mutations using the label indications for nivolumab and ipilimumab. Although our study was a negative study in that there was only one partial response and 4 stable disease at 16 weeks, it really highlights the importance of molecular testing in patients with advanced colorectal cancer. Most of the guidelines have really encouraged, and I would say even mandated, testing for different genomic alterations, because these directly impact the treatment options that are best suited to optimize or give the patients the best chances at survival. And so every patient with colorectal cancer, advanced colorectal cancer in 2026, should ideally get a comprehensive genomic profiling. And so at this meeting, for example, we're going to see the data from Breakwater, the FOLFIRI, which is building on the initially presented and published first-line randomized phase 3 trial, that when you target BRAF V600E mutation in the first line, you're giving the patients unprecedented opportunities at prolonged survival. And there have also been a lot of data for HER2 targeting in colorectal cancer, for example. And so it's really important that every patient should get molecular testing, so that if they have, either commercially available targeted therapies or even opportunities for clinical trials, they can take advantage of such opportunity.
The adjuvant setting in hepatocellular carcinoma has been challenging historically. Dr. Stephen Lamchan discusses findings from the KEYNOTE-937 trial evaluating adjuvant immunotherapy in HCC after surgery or local ablation, and how recent studies can inform current approaches to preventing recurrence after curative-intent treatment.
The 937 study is a phase 3 study designed to study the efficacy and the toxicity of the adjuvant use of pembrolizumab in HCC patient after surgery or the local ablation. The primary endpoint, progression-free survival, and also the overall survival respectively. All patients will be treated with a 1-year use of the pembrolizumab till either progressive disease or recurrence of the diseases or the intolerable toxicity. In this meeting, the result was released. At the time of the third interim analysis, the recurrence-free survival, there was no difference between the study arm and the placebo arm, with the hazard ratio 1.06. Because there's no difference in the recurrence-free survival, so the overall survival will not be tested formally for the comparison, but the data was also presented in the meeting. So overall, we don't see any alarming signal, new safety signal from the adjuvant use of pembrolizumab, but there was no difference in the recurrence-free survival between the two arms. I think there's a two message. The first, we together this study and also the previously we presented the BRAVE 050 study. Probably the immune checkpoint inhibitors is not working really well in terms of adjuvant setting for HCC. Another observation we can observe from these two studies is that the so-called high-risk population is actually not that high risk. For example, in the KEYNOTE-937 study, we can see that at the 48-month time, around 80% of patients either in the control arm, placebo, or the adjuvant pembrolizumab arm still survive. So, which means that maybe the criteria to define this high risk are not adequate to really reflect the high risk phenotype, or actually nowadays the subsequent treatment, the salvage treatment like surgery, local regional therapy or even systemic therapy can kind of salvage many recurrences afterwards. So this actually will help guide us the future design and the development strategy for the adjuvant study. But I think overall in the future, the field is more moving towards the neoadjuvant or the perioperative approach.
Finally, Dr. Xu Chenghua discusses perioperative immunotherapy in gastric/GEJ cancer, including findings from the NeoSummit-01 trial, as well as how the integration of immunotherapy into perioperative treatment strategies has changed the landscape for locally advanced gastric and GEJ cancer.
NeoSummit-01 have three key findings. The first one is we demonstrated the superior EFS and OS outcome in a patient with locally advanced gastric cancer. And secondly, the EFS and OS benefits can be maintained in the patient in the pMMR population, also in the perioperative population. And thirdly, immunotherapy combined with chemotherapy can also reduce the peritoneal metastasis significantly. And this is the three key findings of this trial. Not only NeoSummit-01, also the global clinical trial Hall already demonstrated not only the pathological response rate improvement, but also the superior EFS and OS benefit. So I think in the future, the guideline will recommend the patients with locally advanced cancer to receive the immunochemotherapy plus chemotherapy in the perioperative setting as a standard of care. And firstly, I think even the immunotherapy with chemotherapy improved the pathological response rate, also the EFS and OS, but still more than 50% of patients did not benefit from the immunotherapy. But we don't know which one, which patient, which population can benefit or not benefit. So the future, I think, a new biomarker not only confined to the CPS score, but also the DMMR, but also some novel biomarkers should be discovered for guiding the patient treatment strategy.
Thank you to all of our speakers for contributing. We hope you found this podcast insightful into the expanding role of IO in GI malignancies. Please make sure to follow us on your favourite podcast platform and check out VJOncology.com for more updates.